As a dog lover, yeah, as a dog lover myself, I always love seeing pictures of animals. And thanks to CHSSN today.
Pleasure to be here.
Wonderful. And again, welcome everyone. My name is Kathy, and I'm one of the implementation managers at the KDE Hub. I'll be facilitating this session. And again, this is breakout room number 4, where we will be hearing from the Canadian Coalition for Seniors Mental Health and the Community Health and Social Services Network. I think we'll get started. And in this breakout session, again, we'll learn how 2 mental health promotion projects are using knowledge to influence change. Each project will present for about 20 minutes, followed by some time for discussion and Q&A. And just a reminder that the presentations are being recorded, but I will stop recording afterwards before we begin our discussion. So I'd like to start by introducing the first project we'll be hearing from and learning from, Moving Evidence to Action for Seniors' Mental Health During the COVID-19 Pandemic and Beyond. The lead organization for this project is the Canadian Coalition for Seniors' Mental Health. And our presenters today are Claire Checklin and Dr. David Kahn.
Thank you so much. And so I'm David Kahn. I am a geriatric psychiatrist working at Baycrest in Toronto and co-chair of CCSMH. And I'd like to introduce Claire Checklin, who's the executive director of CCSMH, who's based in Ottawa. So we'll be talking about seniors' mental health today, of course. I think we may be the only one talking about older adults in this symposium. As far as I know, but we're delighted to be here. Thanks for the invitation. And of course, thanks to the Public Health Agency of Canada. This is just our disclosures. So basically I have grant support from a number of different organizations, but no major conflicts of interest, and the same with Claire. I'm going to start talking, and then Claire will pick it up in the second part of our talk. So we'd briefly like to review our origin as part of our story and talk about our current projects. So the Canadian Coalition for Seniors' Mental Health is linked to the Canadian Academy of Geriatric Psychiatry, but the Canadian Coalition is very interprofessional. We've been around for 20 years, just celebrated our 20th anniversary, which is great. I once read that the average life of a coalition is 7 years, so we're doing well. And we had a national symposium in 2002 that was actually the origin of this coalition. And these were some of the characters right at the beginning who helped to support us and form the initial steering committee. It's a much younger me over on the far right. And our mission is to promote the mental health of older adults by connecting people, ideas, and resources. And we note that mental illness is not a normal part of aging. This is our current steering committee. So, this is truly important to have so many national organizations that are working together to support the mental health of older adults, and with very different perspectives. We do have, multiple different professional groups represented here, as you see, but also a number of other programs and national organizations. And we've been lucky over the years to have funding from a variety of mostly national organizations that have provided project funding for us. So our big breakthrough really was back in 2005 when we received support from the Public Health Agency of Canada to develop national guidelines, best practice clinical guidelines, which had never been done before in Canada. And after a lot of work, we produced these 4 different national guidelines that were utilized there primarily for healthcare providers, But we've always taken the position that it's great to give best advice to health professionals and hopefully improve practice dramatically by giving that advice. But at the same time, it's always important as well to reach out to the public, to older adults and caregivers, and give them the same kind of information, just in a different format, so that they can advocate, they can know what kind of care they should be getting, and they can talk to their doctor or other health professionals about what they've learned. This may be of interest, but we received an award from the Mental Health Commission of Canada. The award was, we're giving you this funding so that you can have a very special evaluation done of all of your work. And so, which was great. And this company did an evaluation of what we do after we produce guidelines. And they actually came up with this complicated diagram, but the essential component of this is that when you create national guidelines, all sorts of things happen, things you could not have predicted. And so the guidelines, although they set out to promote best practices in a clinical area, they have an impact on training, on education, on research, on advocacy, catalysts for new partnerships, improving practice, of course, and even affecting policy. So this is what was very exciting for us to see, and it gives us extra energy to continue to do the kind of work that we've done over the years. So in the early years, we got funding from different organizations, and we sort of, you go year to year, and as Claire will tell you, this is the challenge of an organization like ours, is each year you're trying to get new funding because you don't have stable or base funding. We have about 3,000 quotes, members or affiliates of our organization who are connected to us and support our work and disseminate our work, but they don't pay a fee. There's no association fee. And so each year we need to get funding. In the last few years, we've done amazingly well. So this has been exciting. And on the screen there, you'll see a number of different projects that have been funded. One thing we developed a few years ago were national guidelines for older adults on substance use disorders, topical areas, of course. So separate documents for alcohol use disorder, opioid use disorder, benzodiazepines, which are minor tranquilizers that can be addictive, and then cannabis use disorder. Cannabis obviously being a huge issue, especially since the new regulations and legalization. So we also got funding to develop e-learning modules for clinicians and students just about this whole issue of cannabis use in older adults. Not just addiction or use disorders, but just everything we need to know about using cannabis, and particularly in older adults. And we've had other funding for other projects, including a scoping review of mental health services, a study on gaps in research on suicide among older adults, a critical issue, funding for an educational program called ECHO, which is actually linked now to our new funding as well. And then we, at the bottom there, we're working on social isolation and loneliness with some funding from an anonymous private foundation, which is very exciting, a critical issue for all of us, highlighted by the pandemic, of course. And then this project, which has been funded by the Public Health Agency of Canada. And in this project, we're creating clinical guidelines for behavioral and psychological symptoms associated with dementias. New clinical guidelines has never been done before on anxiety and anxiety disorders, a huge area of concern among the population at large, but also older adults. And then we're using some of the funding to produce new knowledge translation tools for the work we've recently completed in the areas of substance use disorder and depression. One of the challenges is you can write guidelines, but if you don't do anything with them, they sit on bookshelves. And one thing we've always tried to do in our organization is realize that and do everything we can to move the evidence into practice. And you know, as we've heard, the overarching theme of this symposium, I think, is how do you actually find the momentum to move knowledge and make it impactful. We'll mention what ECHO is a little later. Claire will mention that. But it's another way of getting information out in a very effective way that I think is worth knowing about. So I won't go into detail here, but just to note that among older adults, mental health issues and problems are very frequent, very prevalent, maybe not surprisingly. Depression, anxiety problems, and dementia itself, of course, is a critical issue, with about 8% of all older adults actually living with dementia at any time. So, and soon there'll be a million older Canadians with dementia in just a few years from now. Delirium, which is an acute confusional state, is really common in hospital settings in particular. That's a reversible confusion, but it has to be recognized and treated, a critical issue. And then, you know, related to substance use, at-risk drinking, 10 to 15% of all older adults actually consume more alcohol than would be recommended in terms of risk. And this just shows, this is suicide rates, so death by suicide, showing that there's a big peak, especially among men, very late in life. So big concern. And COVID-19, of course, had a huge impact on all of us, but long-term care residents in particular, as we know, those living in nursing homes suffered greatly and with very high mortality rates. And then isolation. So our organization created a position statement on mental health care in long-term care during COVID-19 that was published in the Canadian Geriatrics Journal, highlighting the fact that the particular processes that we took were not always optimal in terms of mental health. You know, we wanted to obviously protect people and didn't want people to get COVID and to die, but at the same time, huge hardship by isolating people, not a balanced approach. We also recently prepared for the Canadian Standards Association a whole document on mental health in long-term care. And there are new standards that have just been released for long-term care, national standards. These are the documents on substance use disorders. You can download all of our materials if you're interested at our website, ccsmh.ca. This is the cannabis in older adults modules that are available. And then our depression guidelines, which were updated very recently and are a very big part of this project. There's a whole new section on prevention and health promotion. The original guidelines, which came out in 2006, did not have a section on prevention. And that's how the world has changed, of course. We now know how important that is. And, you know, although there's not enough evidence in this area, there is some. And so we've been able to make specific recommendations about prevention and health promotion. The whole idea is to intervene early, to help people to do to make the changes in their life and healthy lifestyles that can actually prevent depression. So exercise and physical activity, for example, have been shown to decrease your risk of depression, as well as being a good antidepressant. So I will skip that one, and I'm going to pass right over to Claire now, who's going to talk more specifically about some of our knowledge mobilization approaches.
Hi, I'm Claire Checklin. I'm the Executive Director here at the Canadian Coalition for Seniors Mental Health, and I'm really excited to be joining you all today and talking to you a little bit about this current project and how excited we are to be integrating KT right from day one, which is something that we've sometimes not done as well as we'd like to, and we like to think we've been learning about as we go. So As David described, before I go into it, I'll say that we do have a knowledge translation manager on our team who was going to join you today, but she unfortunately couldn't. So I'm stepping in for her. Her name is Lauren Albrecht. And I also notice in the names on the list that 3 of our knowledge brokers are on the call today, Carolyn, Nick, and Avneet. So later on, if you have any questions, I'm sure they'll be able to help you, because we've been extremely lucky to get an all-star team that knows a lot about knowledge mobilization, and that will help us get to the next stages and learn a lot, I think. So as David described, this project that we're talking about today has us creating a few new tools, in particular around anxiety guidelines for clinicians, and also around behaviors in dementia, behaviors and psychological symptoms of dementia. And then, though, the other 2 on the left and at the bottom are this project provides us the opportunity to improve our knowledge translation of some products we had already produced. So the substance use disorder guidelines and the depression guidelines. And as David mentioned, for depression, we updated those guidelines a year or 2 ago, and for the first time talk about prevention of depression. So we're excited that this project will allow us to get the word out about some of the things that can be done to help prevent depression and some of the ways that healthcare providers can support that. And on substance use disorders, there's a few specific things that we're looking to move forward. Next slide. So there you are. There's a description from our all-star manager, actually, of some of what we have in mind, what we hope to influence with our knowledge mobilization strategies. So we want to create awareness and buy-in. We don't want to create products that just sit somewhere. We want them used. We want to obviously impart knowledge, and clinical guidelines extract the very best evidence and sort of grade recommendations based on evidence, and also based on sort of doability and how realistic a recommendation might be in real life clinical practice, both from an older adult's perspective and from a clinical perspective. We hope to shape attitudes, maybe have more healthcare providers ask older adults about mental health issues if they perhaps weren't before, or have maybe more older adults realize that and empower them to bring concerns to their healthcare providers or to their family members or whatever else. Ideally, it would be great to inform research and decision-making and policy as well. We often measure whether or not we've been able to nudge practice change clinically and behavior change clinically, and also the change in practice of older adults and their loved ones as well. Next slide. So as I mentioned, the anxiety guidelines, they are a first of their kind for older adults. One of the first steps you do when you're developing clinical guidelines is you look to see what's been developed before, and then you try to use that and modify it if you need to. And in this case, there really isn't much that has been done for older adults on anxiety before, despite it being an extremely important topic. So we will be developing the clinical guidelines. We'll be developing a number of tools to impart the knowledge from the guidelines to healthcare practitioners. We'll also be developing plain language materials for older adults and their caregivers, and curating a whole lot of tools, not just developing new things, trying to find really good things, even internationally, and maybe borrowing from them or at least referencing them where we can. All along the whole path, we're going to be developing new partnerships. And in the case of anxiety, there's an organization called Anxiety Canada that is out there that a lot of people look to for when they have anxiety issues, but they didn't have content on older adults yet. So we'll be working with them to help them do that, and leveraging some of their communication vehicles, and just trying to make sure that all of us who are concerned about the same things are complementing each other's work. Next slide. So as David mentioned, behaviors in dementia there's some guidelines needed there too. There's some guidelines for clinicians around dementia themselves, but not very much around the psychological and behavioral aspects of dementia. So if a person is living with dementia and depression, or dementia and anxiety disorders, or apathy, or they have differences in their behaviors, which up to 80% of people living with dementia have, then it's important that we have clinical guidance on how to manage those sorts of things as well, how to prevent them, how to intervene, and also how to help older adults and their loved ones manage those sorts of things too. So we, similar types of things, we'll be developing some plain language tools. We're also going to be developing in a complementary fund, a separate project, but that dovetails well with this one, a knowledge hub platform of some of the best practices around the world. And then developing a thorough dissemination strategy for both of those guidelines. Next slide. So as I mentioned, we're now talking about how to prevent depression, what can be done, how can each of us keep those things in mind. And so our KT team will be helping us get the word out about some of those things. A few of them David mentioned around the importance and role of social connection, recognizing early symptoms, physical activity. We're also going to be trying to work a little bit about the role of healthcare providers in instilling hope and positive thinking to their patients. Maybe if they've just been diagnosed with something that's been a fear to them and is now becoming a reality, or the person's health is declining, then trying to offer a little bit of the positive side of things, if possible, if nothing else, the feeling that the healthcare system will be there for them and that sort of thing. So we have somebody on our team that will be helping with that piece. And then substance use, there's a few key things that we're going to be zeroing in on there. One of them is around low risk drinking guidelines. Some of you perhaps saw in the media that the Canadian Centre for Substance Use and Addictions has established new low risk drinking guidelines, essentially saying, 0 is the best for alcohol. And for us at the CCSMH, that's not quite what we've been saying yet. So we're trying to make sure that we're complementing what their messages are while not confusing the messages that we've been giving to older adults around alcohol. We're also excited that this project will allow us to do some cultural adaptation and linguistic translation for some of our tools. A few years ago, we did get a small grant that allowed us to translate some of our key brochures to Punjabi and Chinese. And we're currently, our KT brokers are looking at what sorts of other tools that we have that would benefit from cultural adaptation. So not just translation, but working with groups from a specific cultural area to make sure the messages are appropriate and realistic for their community, and translating them. So we're very excited about that. Next slide. And then we have some overarching fun stuff that we're doing. And I recognize this is a whole lot of information, but we're going to be creating, some stuff we have wanted to do for a little while internally that help us with getting the knowledge out. So coming up with some consistency around the terms we use and acronyms, and trying to message and convey, appropriate terminology that's not stigmatizing and so on. We're going to be doing environmental scans on what works in terms of communicating to older adults, what doesn't work. And I think that some of our assumptions about, for example, the use of technology and older adults not necessarily being savvy are not necessarily true. So it's more about just figuring out where the evidence lies there. I think the next slide is, and we do want to actually complement your presentation, the presentation that's coming next, perhaps, although I know it's for linguistic minority groups in Quebec, so it's a little bit different, but we are working to try to find out how to communicate to the French population in Canada, and in particular, the province of Quebec, a little bit better. Despite huge efforts in that area, we're not always as successful as we'd like. So the last thing I'll just tell you about is Project ECHO. Some of you might have heard about this. It's a genius idea that a doctor out of New Mexico created, called Dr. Sanjeev Arora. He was working on the topic of hepatitis out of New Mexico, and only seeing patients when they're really quite ill, and made it to the city center. And that was disappointing because hepatitis C and hepatitis generally can be treated quite well if there's interventions early on. And so he started to come up with the idea of how to communicate from city centers to smaller towns and to clinicians working in primary care where patients were earlier on in their stages of illness. And so he's created this multi-directional learning concept where those communities teach the city centers, and the city centers teach the communities, and the communities teach each other. And it's really quite fabulous. And as the slide indicates, this concept has spread to 50 countries. So this project that we're talking about today has allowed us to do a mental health in older adults national echo series. We're actually having 3 of them. I think we might describe that on the next slide. I'm not sure, but oh, well, that just describes exactly. So you've got your expert hub team, and then you've got all your learners, and then hopefully that then information then gets out to the patients, and the patient's treatment is improved. And it kind of goes, everything goes back and forth. Everybody's a learner, everybody's a teacher, all sorts of different levels. We've got, there you go. One of the catchphrases is all teach, all learn. And I really quite love that. So the echo sessions start with 20 minutes of a didactic presentation, and then they go on to case studies. And those cases can be brought by anyone from, in the case of our echoes, it could be personal support worker that has a case of concern in their community. It could be a physician, it could be a social worker, whatever the case may be, or somebody working in rural communities or urban communities. And that's brought to the group, and then the group discusses and tries to help them come up with ways to troubleshoot. And really, again, everybody learns a little bit from that, which is fabulous. Next slide. So there you go. So we did have a one go at this a few years ago, right when COVID hit. The Royal Bank of Canada gave us some funds. And so we did have our first national echo sessions for mental health in older adults. And those are the topic areas we covered then. And it was very, very successful. And you can see here that the case presenters were extremely satisfied with the feedback that they got from people. That a lot of the knowledge is shared. It sort of echoes, it reverberates through communities. So it's learned by the people in the session, but then also they sometimes bring it to their own groups afterwards, and then that training just finds it trickle down effect, which is fabulous. Oh, there you go. So there I am, Claire Checklin, Executive Director. There's David Kahn's information, and yeah, I hope I didn't go over time. Sorry if I did.
No, that's fine. Thank you very much, Claire and David, for sharing this valuable real world project experience with us. And there will be an opportunity at the end of our session to discuss what we've learned from your presentation and for some Q&A. So now I'd like to introduce our second project, who will provide another example of mental health promotion evidence in action. Supporting and promoting mental health in official language minority communities in Quebec is a project developed and run by the Community Health and Social Services Network. And our presenters today are Russ Kieber and Amy Bilodeau.
Hi there. I'm sure Russ will be popping around in a moment. There we go.
There I go. I was just on mute. Sorry. So yeah, good afternoon, everyone. And thanks, Kathy, for that introduction. Well, you've seen Amy there. So Amy will be joining me in the presentation. Amy is our program manager for youth and mental health here at the CHN, and I'm the director of programs. So you'll see by the title, everyone. Actually, see by the title, we're trying to stick with the topic around influencing change, experiences from Quebec, but it's really all focusing on our approach to knowledge development. So, and we're going to show you some 4 concrete ways in particular that we do that. So, I just wanted to start, it would be interesting to talk to you all if we could, have more face-to-face conversations, but to see how many of you within your organizations that as part of your mandate, you have knowledge sharing in there. It's something that we added intentionally about 10 years ago. And at the time, I was a little bit skeptical by, having that put in there and the focus, over the 10 years, I can't imagine ourselves not having it there. It's completely, I would say, transformed the way our organization works with our partners, with our clients, with our projects. And it's really shaped, I think, and created a unique niche for our work. So anyways, it's that's our mandate. I want to just explain quickly the CHN in the next slide. So I don't want to spend too much time, but the CHN, we're a provincial network in the province of Quebec, and we support, you'll see there's a population of just over 1 million English speakers. So this is from the 2016 census. Actually, the 2021, we're just waiting on some of the data sets to, we're in the process of redoing this map, actually. Just given that this is the topic of knowledge influencing knowledge, this it'd be interesting to ask you all too, how many of you have ever developed like a 1-page infographic in a form of a map or something that can really explain a subpopulation within your community at risk? This particular map, I must say, is our #1 knowledge exchange tool. It's kind of a crazy thought to think that a map and knowledge exchange, how this has influenced people to understand a subpopulation, our minority community in Quebec. A quick example, even the premier, the second last premier in Quebec, there was a meeting held and this map was put in front of him. And his words were shocked to see that there was so many, for example, English-speaking people that they're spread out across the province of Quebec, and their percentages in comparison to the majority population. So anyways, the organizations you'll see on the map, there's 25 networks. They're funded through our projects. We do have 46 projects funded through that. And a lot of them are actually focused on the island of Montreal. So we do have other maps, but this is kind of our map that shows you the province of Quebec, the English-speaking communities. And you can imagine like all the different subgroups that we all work with, Indigenous English-speaking, the Black English-speaking community is very rampant in Montreal. So with all the subgroups, a lot of you are working with, we work with those same groups, but we're sticking with those that choose that their language that they choose to receive services and supports in is in English. So anyways, you can access this map on the website if you're ever interested to see a little bit more about that. So let's just move in. I want to talk to you, Amy and I are going to talk to you about 4 concrete ways. We tried to think of the concept of concrete, what can maybe you all leave with, and I'm sure many of you are doing a lot of this anyways. So hopefully it'll just simply validate. And if any of you are interested in wanting to have conversations with us about any of these topics, we're more than happy to. The first one is census data. I'm going to take you through a little bit of how we use that and how it has been, I would say, the most powerful tool I could ever imagine in influencing and advocating on behalf of a minority subgroup in the area of mental health. It's been absolutely incredible. Also, sometimes when we have small budgets, we're maybe a nonprofit, we can't imagine the concept of research becomes quite a heavy topic for us. So we're going to try and present some very concrete and realistic and cost-effective ways that you can engage in collaboration with researchers and engage in research that can benefit the work that you're doing. We're also going to talk to you quickly about the concept of a community of practice. I think many of you guys use that wording, but it's really how do you create, what we're doing today, in fact, is a great example of a community of practice. But we'll show you some ways that we go about here in Quebec around knowledge sharing and sharing promising practices. And then the thing we'll do is we'll just show you a little bit how we would create our own model, or we would adapt the model or use existing models as a way to help us all in our learning process. So we'll see how we do. Okay, guys? All right. Amy, you're with me?
Yep.
There. Okay, great. So the first thing I want to talk to you guys is about census data. And again, if we were together, it'd be like, show of hands, how many of you have used census data from Stats Canada before? And in what ways have you used it? What type of data sets have you used? Who have you presented it to? How has it helped and shaped you in your program design and delivery and those types of things? I'll just show you one example of what we do. You're going to see on the screen, this is a, it's in French up top, but it's the RTS. So it's a region in Quebec. And we work with Stats Canada. We build these profiles. So quite often, subpopulations, minority populations, I don't need to tell you all because we all live this, but are often forgotten when we're looking at, just generally looking at sociodemographic population stats that are available through governments, local, municipal, provincial governments. And so working with Stats Canada, you can see that in addition to the population stats that we would receive, we can target particular regions right down to a very small geographic region. And we can look at these characteristics. You can see in the middle, the chart, just by looking at some of those, we can tell the number of English speakers versus the French-speaking population. So that's, first of all, really important when any of us are looking at a subpopulation, is how many of these people live in our region, and what percent maybe compared to the broader population. But if you look at some of the other stats, characteristics we're looking at, we actually can make comparisons and let policymakers, decision makers know that the socioeconomic status of the English speakers in a particular region based on education, employment, below the LICO, so that's low income cutoff line, whether they are a recent immigrant, whether they are living in lone parent families. So we get at some of the risk factors that could possibly come up. So it really helps us to not only work with community organizations to help them understand their own population, but it's certainly very good for us in terms of advocating and working with local and provincial service providers and stakeholders to help sensitize them to the needs of our population. So I don't want to walk too much more. StatsCan, I'll do a little plug. Go on their website. It's super easy. They've really improved it. There's all kinds of data sets and information related to COVID-19. Do a little search on there. You can call them up. So it's a big discovery for us about, I would say, 15 years ago. And I can't imagine the CCHEN and us not working with census data the way we do now. It's really shaped and helped us so much in our advocacy efforts. All right, moving along to collaborative research. So I'm going to start a little bit, and then I think Amy's going to pick up on the second part of this. So what I wanted to talk to you guys a little bit about is I think many of you are trying to look at populations at risk. We are no different. So when we're looking at the general population of, say, an English-speaking community, over 1 million, we start to ask ourselves, well, where are the vulnerabilities within those million? Not every English speaker has the same level of vulnerability. And so, interestingly enough, we started to come across a couple studies that were done on men. And men were starting to come up in the province of Quebec as showing a significant level of vulnerabilities we were certainly interested in it because from my perspective, there was very little research done on men in itself. So we actually reached out to the researchers that were involved in doing research with men in the province to see if they could add a sample size in their questioning for English-speaking men, so we could actually get some data on English-speaking men. It was an amazing collaboration. First of all, it cost nothing. That was the first thing. Secondly, the research team was happy to integrate a few questions and to provide us with a separate report that could talk about some of the unique characteristics of English-speaking men in comparison to the majority population. So I think Amy said we just got a little infographic. So this was the other thing that we often do, like many of you do, I think, is create infographics. So not many people read the big report. You don't need to go into detail, obviously, and read this report in general, but it's just to say that we found that the more that we did collaborative research work with different researchers in the province, in particular to the men's, we found there is significant increased vulnerabilities of English-speaking men in the area of mental health related to COVID, their experiences in parenting, and the list goes on. So we are targeting English-speaking men among other subpopulation groups as a very important vulnerable group. But it's an example of a collaboration that I think a lot of us could make that we don't always think. We think we got to conduct our own research, or, it's an overwhelming task. But doing a bit of a scan to understand what type of research is currently happening, and how can we collaborate in that research to maybe get some results and information that can help us in our movement, in our advocacy, in our program design and development, that can better understand sometimes subpopulations that are sometimes forgotten in the original research design. So now it's over to you, Amy.
Yes. So to speak to research collaborations from another perspective, we collaborated with the community. So with the community organizations themselves under our network, we decided to conduct a non-academic research at the community level, born of a collaboration between these groups, thanks to our ability to bring them together, and stakeholders that are of interest within the realms of mental health and youth, to create what we ended up calling a youth pulse check. So we decided last year in 2021, we ran this. It's not last year anymore. We decided that we were going to all together come up with a survey of the questions that we thought would target areas of improvement for the programming that we were going to provide with the funding, as well as evaluating the accessibility to services as they stood now, which at the time was during the pandemic. 2021 going on to 2022 was still a very precarious time. And so we were evaluating how youth were interpreting and interacting with services and supports at that time, and what community groups could be doing for them. So that was what we were aiming for in this survey. We also took the opportunity to promote the Kids Help phone line, which is one of the few bilingual 24/7 crisis lines available in Quebec and across Canada. So we targeted to a range of youth, and aware that there's a pretty big diversity among our rural and urban groups. The multiculturalness of our English-speaking community is pretty important. And there you go. So just an example of what that looked like. Then we packaged the results into, I guess, what we can consider the language of research, but to inform, again, our program activity design, and also to help us in efforts raising awareness back to health partners, which are majoritively in the French-speaking sector. So this is equally translated in French, of course. We summarized the results into a one-pager infographic, but there is a full report available on our website under our document center, where you'll find just about everything we've talked about today and we'll talk about. But if you're interested about learning about the specific results and findings related to youth voice in mental health, please go visit it. I'm always happy to talk about it. I could talk about it forever, but in the interests of our time today, I'm just going to keep going. So feel free to hit me up for a question anytime after. We also took the opportunity to take the information and translate it back to youth. Our commitment to having their engagement not be a one-off spin-off activity, but for it to be a continued conversation with the organizations of our network moving forward in their program development to really entrench it in a meaningful engagement was really important to us. So we created an Instagram reel, which was the method that we reached out to them in to inform them of what came of the results and to deepen the discussion moving forward. So each community organization was welcome to use it and share it in their regions and build upon it as a tool for youth engagement moving forward, which fed into the recommendations in any case that came out of it all together. So we were spot on moving forward in that direction. Now we're going to talk about creating a community of practice. So I'm going to throw it back to Russell and see where we go from there.
All right. So just to finish off, Amy, if you just want to go up really quick, I just want to mention too, just up one more. So just to finish off a little bit was just, collaboration with researchers and research projects, I think is a really good and cost-effective way that we can get results and information on subpopulations that are often forgotten. But also what Amy just showed you was something that we engaged in. This was our form of community-based research. And I think here today, we want to put this forward to, encourage you all, or any of you that are thinking about doing a bit of your own research work. Amy can tell how much, it did take time. We're not going to, hide that fact, but with a little bit of help from some research support, I fully believe that, community-based organizations in particular, smaller organizations that don't have big budgets, we can engage in research ourselves. I think it's important to collect data and information. And what Amy mentioned, she's packaged it in such a nice way that it comes forward as a really nice way to inform and support other researchers to take more of a formal research approach using this data. So we'll see. Anyway, okay, sorry, just wanted to put that little plug in there. All right, let's move on to community practice. Before I get into this, I think many of you guys can imagine that like you all, you're working with vulnerable populations at risk. In the English-speaking community in Quebec, there's the other concern or issue that we have is that it's majority French-speaking service providers. So when you turn to mental health, by no fault of anyone, there's a lot of mental health service providers that are not comfortable speaking in English. So the English-speaking community, in addition to having, some lower, a profile that's more defavorized, there's also the lack of services that are available to them. So there's kind of a double crisis happening there. So the community of practice was, I would say, it was created maybe our vision and approach around this maybe about 15 years ago, because it was so important for us as a community to share and learn from each other. And so it went far beyond just sharing knowledge and information. And it actually became a bit of a support network for each other. So the first thing I wanted to say is that this framework that we have here, you can scan it if you want, take a look at it, is the community of practice has been something where we have focused on building relationships and being peer supports to each other as the principal #1 outcomes of what we're doing. Because once we've established that, sharing and learning can happen. So a lot of what we're doing is really around building relationships among organizations, like-minded people that maybe don't work typically together or haven't before. They share information. And we're not reinventing the wheel in many cases. So I don't want to go through all of it for you, but I'll just show you a couple of things at the bottom. I don't think you had another slide brought it up. Yeah, so there you go. So what type of things do we do when we're working among our stakeholders and other community organizations and our team is we do things like this. So requests for information. So sometimes knowledge is within the group. We're seeking experience. We found that it's certainly in mental health promotion, the field is still somewhat so new. We're all still trying to learn and use best practices and evidence, but there is different levels of experience that we can gain from. Obviously, sharing of resources is a common one, but you'll see informal mentoring. I don't know how many of you have that in your work or on your teams where, you know, you have somebody who has a lot of experience in a particular area. Somebody new comes in with a lot of passion, you know, a little bit of mentoring can go a long ways. Obviously training, recognition, and other things like that. So you could take a look, but it's a full approach that we've adopted to community practice that we framed. And I want to just turn it over to Amy so she can show you concretely what that means in her project that she's running.
Using this model actually has incredible value, taking one model into all of our community practices within our organization, because we're advocating for the value of the work that involves with the groups, and it puts them all on the same playing field of understanding what kind of knowledge exchange we're looking for together and how the collective will be moving their objectives forward, because typically it's usually a collective brought together from being vested in the same outcome. So within the population, within the group of your community practice, they might be looking for different things, which is what this little graph here kind of points out. So you can angle your learnings, insights, and everything towards their interest within the community of practice. And also see where others have tread before successfully in achieving the same outcome that we talked about. It breaks apart the silos when we know that about community practices, don't we? So community practices can materialize in different ways. In my community practice, which is for youth and mental health, we do gatherings about 4 to 6 times a year virtually, where we leverage the exchange of information, sharing of promising practices, sharing of learnings, talking about challenges. And this has really been beneficial for the groups, not just to connect, but to have those moments of touching back base. And I think I have a few groups in our conversation here today, so they can speak to that too. We have a Facebook group that we use as an ongoing resource sharing platform. It also allows us to do some problem solving and touching base with people. Useful for resource sharing. In fact, to the point that I think I'll show it to you now. It's well worth a quick look to see that I think you're all following me still. Our community of practice has a little explanation, very similar to what you saw in the community practice model that we have. We have featured information. Most importantly, we have, I just shared today, information about an upcoming session being offered free of charge in French for a conference on mental health and youth. A little bit of awareness sharing, resources that are outside of Quebec. We learn a lot from other organizations. Why not? Sharing what they're doing. We have our organizations. This is one of our participants who's sharing a talk about gender for youth well-being, more awareness raising on that. So other groups can see it, be inspired by it, and consider hosting the same one and talk to each other about resources that might be willing to spread their knowledge across provincially, which happens a lot. Different ways of working with youth adults, so methods, sharing methods of how things have run. And you might notice the KDE hubs right there. So I was talking about the mural board that we did yesterday. I thought it was very cool as a way to engage with youth. Another learning opportunity for capacity building in the organization. So a training that can be offered on peer support and better understanding if you want to be leveraging peer support in your actions. Myth busting, of course, stigma breaking information, stuff about youth. Of course, we're always coming back to that. Youth are not a monolith. They're the centric area of the developments that we want to be making. Another organization adding a blog post about healthy schools. So I could go on forever, but I'll leave it at that. So our community, I think, is benefiting quite nicely from that source of practice. And then lastly, and possibly most importantly, is our one-year retreat. Once a year retreat happens in person as a gathering. So as you can imagine, that's a lot of planes and travel, and it's quite costly for our rural regions, but we assume the cost. I think it's really important to come together and equalize the grounds of their participation and what they have to bring and their skills and expertise to the group. So this is a learning opportunity event. We spend a lot of time in learning and development. It's also celebrating success moments and enormously a relationship building opportunity, not networking, relationship building, because they're already part of our network. They need to be connected in order to make the virtual gatherings work. They need to be connected in order to feel like the Facebook sharing space belongs to them. So everything kind of reposes gently on the success of the connection at the retreat and other such events that we offer, like trainings. This is also where the informal mentoring might come in, those that will connect and move forward on what kind of needs they have together and expertise sharing that they can do cross-versally. So we see just a little image there of what it looks like when we're in person, making the most of it. That was us last November, meeting together in the countryside. So the next part about developing and promoting models and tools, I'm going to hand it back to Russell as he has a section on community development.
And don't worry, Kathy, we're almost done. Like 3 more minutes. We thought we would title this last one called Models and Tools as a way to inform our learning process. I mean, I know a lot of us, we use models, but I just want to do a little promotion to nonprofits, small organizations, to think about that you also have the capacity to build tools. We don't always have to rely on universities and scientists and, yes, we're going to use all those tools, but the practice that we're doing at a community level is extremely informative. And I think it contributes to the research community as well. And I think the more that we can share our experiences through developing our own models and tools, I think it can really help in many ways. Certainly it helps to frame different approaches and best practices. So often we form it as blue literature, so it's not published information, it's information that's created by ourselves. So we're going to show 2 things. One, how we create our own models and tools, and the other one is how we use existing models and tools as a way to create help us in our learning and to mobilize partners and into understanding and using and adopting best practice approaches. First of all, partnerships. It'd be interesting if we were together. Raise your hand if you've developed your projects are involving partners and developing partnerships. I think it's integrated in most of all our work. Mental health promotion, all the different talks we've had over the last day and a half. I mean, working on the social determinants of health promotion, looking holistically. We know that we have to work outside of the health sectors. We have to work with all kinds of different sectors and looking at mental health promotion. So what we did was over the years, we started to document the different stages of partnership development that people felt that they went through, just so we can understand what does it mean to create a healthy partnership? What are the steps that somebody's new that might go through so that they can understand quickly, like the Coles notes, like partnerships take time. You need to build relationships. It's not necessarily linear like this shows, but there are definitely some steps to creating strong partnerships. So it's part of one of the core activities of our network. We all, even in our mental health work and in our other sectors, we want to engage health professionals and other partners in our projects. Mm-hmm. So you could scan that if you want to take a look. We have all kinds of information around creating partnerships. During the COVID, when it first hit, I did a webinar on partnerships. We created one. So it's there on our website. You could take a look at. So it's like 50 minutes long that explains this model, but gets into talking more about partnerships. But this is a model that we've created kind of from the bottom up, working with myself kind of as a quasi community researcher, working along those 23 organizations you saw up top in the map earlier on. So we'll turn it over to Amy.
Another model that I'm using in my approach to inform and framework and guide the organizations that are within the mandate, the funding mandate, and their partners, is working on this this approach, these three areas that we deem to kind of, maybe it's arbitrary, but split up a little bit the work that they're doing in mental health promotion, if it falls more under targeting protective factors or under education and mental health literacy and stigma reduction, or, you know, going towards population groups that are more targeted, that are at risk under mental illness prevention. So youth exiting care, you know, it requires a different approach, or trauma-informed approach. It gets a little deeper there. So many of our groups are working in all three areas, but some of them are kind of fixed in one area. So we thought this model was useful for them to understand the scope of mental health intervention and promotion, sorry, not intervention, promotion, and where they intend to take it.
Amy, I'm so very sorry to have to interrupt you here, because this is also very interesting, but I just got a warning that our breakout room is going to close in a few minutes. So I would like to tell everyone that at 4 o'clock today, we have a coffee break. So people can, oh no, we don't actually, no. You'll have to take the discussion sort of informally. I do want to thank everyone for sharing, and just wondered if we can take the last 2 minutes to open this up to the audience to see if anybody has a question that they would like to ask our two projects today.